Thank you for the opportunity to Eksoch and the Development Dialogue team. So what we do at iCure is we are providing healthcare to the last mile using technology intervention, and we do provide in a hub and spoke model. So in the hub we have got doctors, diagnostic setups, pathology units, and in the spokes we have got the mobile medical team which covers these areas few days in a week. And on the other days we have something called as community health workers who are actually picked up from the community, mostly women in the age range of 20 to 45 years of age. We give them training on both technology and the healthcare things, and then we provide them the various handheld devices such as mobile phone, point of care devices such as BP, ECG, sugar testing machine, and corporate hemoglobin testing devices. So our aim is that with few number of doctors, which we have a huge demand in the supply gap, how we can provide affordable and sustainable healthcare to the last mile. So happy to tell that we are a for-profit entity and we have achieved EBITDA positive for the first time. So maybe one of the first organizations to work in the primary healthcare space to move into a sustainable model. And in this way, we are able to provide a complete holistic care right from the last mile to the clinic level, and if they need access to secondary, the tertiary care need, they can be seamlessly referred to various hospitals. And we also believe in a transformative ecosystem, so we can talk about it in that.
Hi, I'm Shelley and I used to be a surgeon. I think some of you might have heard me downstairs in the main gallery. So I'm the founder president of Operation Asha. We are providing last mile delivery solutions for health for the poorest of the poor in urban slums, in tribal areas, in hard to reach, inaccessible rural areas, and even in the islands of Cambodia, which are really where patients are scattered and far away. So what we do is we've collaborated with the government. So on one hand, we have the government infrastructure, which has got the free medicines and the doctors, and that's why we don't need to buy medicines and hire doctors like you are doing. What we do is to provide the delivery. We get the diagnosis done and the medicines done, and then we put it in the nearest center to the patient's house. Now, typically in the slums, there's an entry point. All people go past early morning, and there could be a temple there or a mosque there, and they can stop early morning, late morning, take their medicines. We have a health worker from the community they serve who's trained in this kind of work, and we are extensively using technology for adherence. So we have these fingerprinting devices, low-cost, minimal text devices called e-compliance. This was created by Microsoft Research, and now e-compliance is in 8 countries. And what the patients have to do, they are registered by their fingerprint. They give the fingerprint at the DOT, at the TB treatment center, and the screen turns green and says so-and-so logged in. And then they take the medicine and go, and real time we get to know if someone has not come. So the follow-up is immediate and prompt. The challenge in TB treatment is that patients come for a few days, and when they start feeling better, they stop treatment halfway. And that's how drug resistance sets in. That is a horrifying disease, and takes thousands of dollars to treat, 2 years, 6 months of injections, side effects, etc., etc. So we are turning the tap off for NDR TB by providing last mile delivery. We do not allow a single missed dose to happen. At any time a patient misses the dose, we go to the patient's house, repeat the counseling, and counseling is an integral part of our program, because we tell patients TB is curable. It's not a curse from the gods. And if you get yourself treated, you will save your family. And this way we are ensuring adherence, we are ensuring prompt treatment, we are tracking family members and testing them for TB, and thus our detection rate, adherence rate, all has gone up. We have a scalable, replicable, fully sustainable program, and we are the largest NGO in India in TB treatment.
I'm Subodh, and I'm a practicing plastic surgeon, and I've taken the liberty of showing what we do on slides, if you permit, because we are focused on a particular condition called cleft lip and palate, and unless I show you some photographs, you will not understand what it is. And I've learned a lot sitting through the whole day and learning so many entrepreneurs, so many achievers, and so many young leaders. This has been a great learning experience for me. So, the cleft lip, one out of 700 children are born with cleft lip and cleft palate, but you don't see many of them in the social places. You don't see them in movie hall, in the schools and other places, because they don't go out in the social gatherings, because their families do not take them there. They do not go to school, and they do not study, and they're poorly nourished, and they slowly become a social outcast. So when I started in 2004, every year I used to organize a camp, a free camp for patients who could not afford in February. And in 2004 I organized a camp for cleft patients, and 135 patients came in, which was amazing, because in Varanasi, where I studied in BHU, we used to treat 100 patients in 1 year, and this was 135 in 1 day. So we tried to think how could we help more and more patients, and there were patients of all ages. 65 years old lady living still with a cleft lip and dreaming that one day this cleft will be repaired. And there were not enough facilities available in so many different places. The surgery was blocked up. They spoiled the lip completely because there was no training, no good facilities available, and many patients died because of the poor treatment they were given to. So, and there were hundreds of thousands, and I estimated 1 million patients were waiting for cleft surgeries and 50,000 for being born every year. So, and there were a lot of burn patients also living for several years with such crippling deformities they had to lie down to eat. And such severe deformities, and this girl also had a crippling deformities of both her hands. So there were 1 million waiting patients, there were limited facilities, limited resources, and they were treated by untrained doctors. So we joined hand with a Smile Train, and then we organized a very innovative methods of outreach programs. We had leaders of several teams. They were trained, they started going to the fields. Young mothers not knowing where to take these children, and young daughter-in-laws coming to the camps with great hope. And somehow the mothers were thinking that they were guilty for it, and severe deformities which could never be treated anywhere. And the patients used to turn out in big numbers at all ages. You can see this lady is about 40 years old lady. At all ages, the patients were coming up with all ages. And average age of the patient being treated in our hospital was 11 years, when it should be treated at less than 1 year. The patients were turning up in huge number, but then we were not able to reach to many of them. So we had a toll-free number. Then we gave a missed call number. So these people could just give a missed call and we will reach back to them. So we advertised this number, and they reached us to us. Then while they were there, they were all from a very, very poor community. So while they were there in the hospital for 7 days or so, we gave them vocational training so that when they go back home, they could adapt to their family income. And we also worked up with various organizations, including Indian Army, to go to the far-flung areas and help the patients in the border areas. So in 2004, when we started, we had a small area where the patients were coming from, and then it scaled up in a more states, and by 2014, patients were coming up most of the northern areas of the northern and eastern areas of the India. Inspired by GS Memorial's success, 150 or more centers joined hands and used our methodology, which was published, scaling number of free cleft surgeries done in India from 5,000 a year till 2004 to 50,000 a year by 2002, making India the most successful country in tackling the problem of cleft. And if you consider Varanasi as a country, so as a country, India was number 1, China was number 2, and Varanasi was number 3. So we were doing the 3rd highest number of cleft in the world. And there were patients, this young girl, Pinky, and whose life is showcased in Smile Pinky, was hiding behind the mother, not looking up. And after the surgery, she became full of confidence. So this is the change that the surgery brings to their lives. And of course, this went to the Oscars, and we won the Oscar for this was captured. The whole methodology of our working was captured in a documentary called Smile Pinky, and which eventually won an Oscar award. And there are many other documentaries made on our hospital. So, but then we were still not reaching to all our patients, and the biggest problem was to provide them speech therapy. All cleft palate patients would need speech therapy, which is usually hospital-based all over the world. And these patients were coming from 8 different states from the far-flung areas. They couldn't come to any hospital to get speech therapy, and speech therapy was not available to them. So that should not mean that our patients will never get speech therapy. So I kept on thinking. So initially we insisted on training the parents. Then we developed home modules of speech therapy and we gave them in a small cassette with a cassette recorder, cassette player. We also made DVDs, audios and videos that we gave them. When Skype came, we started providing speech therapy on Skype. So there were cassette players, DVDs, and then Skype. We launched our Skype program, but not all of them had access to net. Not all of them had access to a cyber cafe. So then we developed few centers. We used technology which has become widely available and cheap. So we wanted to reach out to them to have a remote access medicine. We gave this project to 4 MIT students, management students who took the full session project on this, and we also took services of Boston Consulting Group. And these 4 students were there in Varanasi working on different aspects of remote access medicine. And we chose locations, we chose the technology, we checked it, and then as a pilot project we started 10 centers, one in UP, the center here, and then 9 other centers across 4 states. And now we developed online dynamic softwares to manage this. So from these centers, now our speech therapy program has improved tremendously. A lot of patients come to these centers and they get speech therapy. Our follow-up from those areas have increased by 100%. And by our recruitment of new patients have increased by 27%. So we now sitting on my chamber, I can see a lot of patients, new patients, a lot of follow-up patients, and give them a definite date when they can come to the hospital and get treatment. And my speech therapist can give them speech therapy while there is still 500 or 600 kilometers away. So I think of, now this is the existing network that we have, and I think of this kind of network where there are many nodal centers and there is a central coordinating center, and this kind of remote access medicine can be taken up to provide all different kinds of healthcare. Imagine the distant areas where expert healthcare is not available. If all PSCs have one such center which are linked to the district hospital, or which are linked to the medical college, and a doctor or health worker there has a problem with a patient, he can immediately contact an expert who can give an advice. There can be a call center where retired doctors or senior doctors can donate 2 hours a day, and they can provide an expert help at a time of need. While the patient is being transferred, that help can be provided, and many lives and many complications can be saved. So we have this kind of patients now who have been waiting for years for treatment, and now they come to us and get treatment. This girl who waited 9 years to get surgery for this, and now a documentary was made and which became viral, and which was on a National Geographic homepage, won many awards. Patients improving. I mean, this is in itself, this patient is a case study. She was begging at the bank of Ganges here, and she was brought to me by somebody. I treated her once. She needed another surgery. She came again, and I asked her, "What are you doing now?" She said, "I'm begging." So I said, I won't do your surgery if you continue to beg. You have to do something else. You have to leave begging. So she promised to leave begging, and I did my surgery in a forgot. And with some of the guests, one day I was on car, and I saw her selling those picture postcards and bindi and those things. And then I met several times. Now she is a tourist guide. She has her own bank balance. She has her own bank balance. You can find her on the back of Ganges. She has her own bank balance. She bought a small house. She is a great entrepreneur, I would say. So these kind of things, these are changing lives, and the revenue that we are generating is in terms of happiness and love. And we remain poor in terms of resources, although we are earning a lot. So these are the life-changing moments for the patients. We have a promise for them which we deliver, and we see happy patients coming back to us. Thank you.
I work with Save a Mother organization. We do very boring work compared to Doctors Bodh and Shelley. They do the last mile healthcare, we do the first mile healthcare, which is taking the health to the doorstep of a person. If you see the design of healthcare all over the world is supply driven, that if you have a healthcare problem, you supply doctors, you supply drugs, medicines, surgeons, CT scan, MRI. As every healthcare solution is a supply driven. And almost nobody has worked on the demand side of healthcare. What do you do with the patients or the people when they're healthy and before they hit a primary health clinic or a private doctor? Is there some work to be done there? This is an unknown area, so we plunged into it. Entry strategies, maternal child health. We started work in UP, then we expanded to Gadak in Karnataka and Nizamabad. And now we are, for the past part in Jaunpur, we work in about more than 1,200 villages now, cover about 1.5 million people at home level, maternal child health, the idea that mothers should not die during childbirth. It's against evolutionary logic. If mothers died in childbirth, species will disappear. So there's something wrong with the culture, not the biology. Because nature wasn't created like that. So the problem and issue is what is it? So our job is to find the problem and find the solution at the ground zero level. That is before they come to the doctor. Maternal child health, for example, you can decrease maternal mortality by doing only 5 things by 75 to 90%. And those 5 things are so simple, you wonder why people aren't doing it. That is 3 to 4 antenatal checkups, 100 iron tablets, 1 tetanus toxoid injection, institutional delivery, and stay in the hospital for 48 hours. That's all you have to do. If you just do this, maternal mortality comes down. There's a data available to others that this is how it's to be done. So we apply the same 4 or 5 bullet points in the areas we work, and lo and behold, our maternal mortality has come down by 70 to 90% in under 3 years. In fact, I was sharing with the Golden in Gadak last year, where we were working in the sandbox, Sugri sandbox. In the last 1 year, this is the data ending July 2016, 12 months preceding that. For about 2,500 deliveries that were done, that we follow, there was no death, 0 death. Now you can say small sample, which is true, and it could be extrapolated as higher number. In Amethi, where we work, 6 months data, similar number of pregnancies, we had 2 deaths, which translates to about 80 maternal mortality rate. The country average is 200, UP is around the same, Karnataka is about 140. So this idea of taking healthcare to the home of the patient works. So we create a field force of volunteer health workers. We have trained close to 27,000 Arogya Saki, these are the ground level workers, and smarter ones, we call them Sasaki. It's about 3,000 that we have. So now they're scattered everywhere. They're aware of it, they're sensitive to it. They're in every village has 4 Sasakis. So they are messengers. So we compress every textbook into 5 bullet points. So we started a population stabilization program through the same messengers 3 years ago, funded by PFI. And they deliver. We add 1 more page to their education. They deliver. We're going to work with Shelley, and we started some work in TB detection. And our data, 2 pilot studies that we've done, we're able to detect 3 to 10 times more tuberculosis by going to the households. We connect with DOTS people later, but we don't give medicine, we're not doctors. Our job is the no man's land, what happens there. For me, every poor man has a birthright to live to 67 years. This is the data of last century that shows us that you don't have to be rich to live to 67 years. You can live by just little tweaking of your healthcare. Thank you.
I have been working with some of your organizations closely, and I also get to meet a lot of organizations working in the field of healthcare. So I just maybe 2 questions I'll ask, and then after that I want to open it up to the group. One of the things that I see is when we take education and maybe other fields, people are willing to immediately go and grab some technology to deliver it to the last mile. But at healthcare, we know that there are a lot of technologies, maybe smartwatches and all kinds of things. But then when we talk about going to the field and getting it, to the ground force with technology, that's always been a challenge. But I see that, okay, the team sitting here are some, people who have actually applied it. So can you talk about how technology is helping you, maybe even Sujay, Dr. Shelley, and you're also doing telemedicine, right? And Dr. Ganju, I understand that you're planning to do it. So maybe can you throw some light on it?
So let me begin by saying that technology cannot be made in a fancy lab and then just dumped on the disadvantaged. Technology has to be made for the people, by the people. So our technology device was created by Microsoft Research from Bangalore, the Bill Gates firm, but it was made in the slums of New Delhi. And when we made it, we kept in mind the patients and the health workers. Not only their literacy level, their cognitive abilities, but also their cultural perceptions were kept in mind when we thought of a device. So how do we have a proof of visit? We can have retina prints, we can have a voice print, we can have a fingerprint. Retina print, everyone got frightened. Voice recognition, the recognition was very poor. But a fingerprint is ingrained in the psyche of the people. So they perceive the fingerprint as something, the past that we have said, you have to do it. You give your fingerprint, you have to take your medicine. It sort of reinforced their belief in the government's TV control program, and also they perceived it as dedication of effort on our parts. And the health workers, we made it with minimal text, and now we've developed a text-free application where the patient is not registered by the name, but by an icon. So when the patient gives her fingerprints, a whole lot of icons appear. There's an apple, a butterfly, a rabbit, and the patient can choose to be a rabbit. So every time she gives the fingerprint, the rabbit will appear on the screen, and the same rabbit is on a treatment box and the treatment card. So keeping these in mind, we have developed the device. And only then has it been successful. There have been many technologies, and I think all the doctors will agree that the country is flooded with health technologies that are gathering dust, and that have just been a wastage of money. Millions of dollars have gone in the technology for health industry.
Yeah, I second Dr. Shelley. In our case also, for example, my background, I have worked in IBM Oracle as a technocrat. And when it comes to India, India is very different from the developed countries. So in our case, we have really been on the ground, and the design has been bottom up, meaning that what challenges are there, what is the people who are actually named, and how can we design the solutions, keeping in context these people in mind. So for example, in our case, the WIMS, it is completely driven bottom up, keeping the health workers in mind, what kind of user screens that they will be having. And in addition to that, there have been several other things. For example, the framework for the mother and child, which will be able to detect the high-risk pregnancies or the early child development, which we have designed with University of Michigan. Similarly, we are working with the University of Oxford and IIT Kharagpur for oral cancer detection on a microscopic camera fitted on a mobile phone. So what we all know is, as an entity, single entity, IQ will not be able to provide and solve the entire problem. It's a complete ecosystem which we have been able to build, right from the ground partners like Tata Trust, Pradhan and others, to the research partners with whom we are working. So in this way, we are able to transform the ecosystem and applying technology wherever it's required, be it in terms of data analytics or predictive algorithms, which will help us to pinpoint the certain cases, be it the outbreak of dengue or malaria or any other things, right from the location from where the first occurrence was there. So this is how we are applying technology, keeping in mind the rural context, keeping in mind the ground challenges and things.
Now we are using technology as it adjusts, and which the people are very familiar with. So we are not creating a high-end technology designed for the condition, but we are using existing technology, simple smartphones and mobile 3G network and all that. So our field force moves with a smartphone, and in our case, you can see the diagnosis is easy. They can just take a picture, a short diagnosis, and they can just send it to us. And they can, our software is also mobile compatible, so they can immediately upload it from there, and we know, and we can communicate. Similarly, our speech therapist can get a voice sample when the patient is talking. And then she can design a specific speech therapy module for that specific condition and send it to the patient. So they can hear and train themselves. So we are just using technology in that way. And now, there are a lot of patients. We have thousands of patients with similar problems. So we are now starting a webcast. We will give it a time for a particular kind of speech defect, and they will all log in, and our speech therapist from our hospital will give a webcast where they can all listen to it and interact.
The whole panel is far ahead of us, user technology. Technology has three roles, at least in the kind of work we do. Number one role is, can we modify behavior through technology? Because we're in the behavior modification space. How do you change a person A's thinking by the kind of work we do into become a healthier person? And behavior modification, I can tell you, I'm a physician, is impossible on an individual level. My son smokes, and I've not been able to modify his behavior. But somehow behavior modification is easier when you work with groups, like the religious groups or the armies of the world. Similarly, healthcare, if you form them into groups and give the sermon, it somehow works. The question is, if we work at the speed which we are working, we can open up a new village. We have the capacity, a new village every day, and that's a fast speed. But at that fast speed, it will take us 1143 years to cover whole India. So the problem is, can we use technology on a scale for behavior modification? We've done a couple of experiments locally, miserably failed in them, about which we haven't given up. We thought the problem is ours, we had to redesign it. And before I came to the session, that's why I got late, I was talking to Mr. Modi's group to see if we can use the telephone messaging to vast number of people, 1 billion people, and see what happens there. So we agreed on conducting a pilot and creating some content and throw it out, collect the data back, improve it, and hopefully we'll be able to modify some behavior. That's user technology number one. Number two is, as people mentioned, the technology is culture and individual specific and a disease specific, like tuberculosis, cleft palate. Technology is not panacea for everything. You can't use technology to diagnose and treat malaria. It has to be disease specific, and oral cancer detection can be done, but you can't use technology to do stomach cancer detection. So it has to be disease, individual, and culture specific. And lastly, the user technology that we are planning is also monitoring your field force. Are they really there where they are supposed to be? And that way we use fingerprinting and GPS systems. In fact, only yesterday evening, I want to recognize two of my colleagues here, Anwar and Mr. Yadav. They work with us in Amethi and Jaunpur. They're the real field people who have the knowledge. So we sat yesterday and created a whole high-level design of our MIS system incorporating these three issues, which will be GPS, fingerprinting, iPads, etc., etc. I have a meeting in Delhi 23rd morning with the technology group to see what we can do. So technology, in summary, can be used for scaling up. Number two, can be used, has to be culture, individual, patient, disease specific. And third, it can be used for field force monitoring.
Great, thank you. Another question, always related to healthcare, is that I find people, they really project very high costs. I know health is not cheap, and there's always a high cost involved. So how are you tackling that, whole aspect of trying to bring down the cost of providing service?
The reason is, there are two reasons. Number one, a high-cost program cannot go to scale. It's all about going to scale. There are millions of TB patients. There are thousands of people with cleft palate. If you are using all your resources in 2 patients, that's the end of the program. And the second reason is, and I think this is equally important, is that most of us who are funded by donors, I think the donors' money is a sacred trust. the money hasn't dropped from like manna from heaven. It's someone's hard-earned money, and we have to make it go a long way. This I feel is very, very important. So in Operation Asha, what we did is, number one, we decided, let's give a leverage of 4 times by using the free existing public infrastructure that is underutilized rather not being utilized. So we are not hiring doctors, we are not paying doctors, we are not getting the tests done, we are not buying medicines. We are doing nothing as far as diagnosis and treatment is concerned. We are providing the day-to-day delivery, the day-to-day monitoring. So that way we are giving a leverage of 4 times. Then what happened, we studied some other TB treatment programs in India and other parts of the world to see who they had hired as their TB treatment workers. So other NGOs had taken a little room in the slum areas, they were paying rentals, they were paying bijli pani, and they were paying someone with a small MBA degree to sit there. Now 2 things here, the costs are high, and someone with a degree is not going to come before 8 or 9, but that is the time people have to go to work, and patients typically are going early morning before they reach work. So that is not going to work. So utilizing existing infrastructure brings down costs. Number 2, utilizing semi-literate people wherever they work, wherever they belong to. We are not sending India people from Cambodia. We thought we'll send our program manager, and he was getting 50,000. He asked for a salary of 1.5 lakhs. So we said, okay, goodbye, we don't want you there. But local people from Cambodia are charging a local rate. So apart from the country manager who's from Singapore, every person is a local person. Now if we get workers trained in, say, Orissa and bring them to Delhi, they will not be able to manage. There will be cultural differences, and the salary they are getting over there, might not be able to manage in a more expensive city. So it's all about cost cutting. Now the important thing about cost cutting is we cannot cut down costs too much either, because then you miss out on the best talent. So NGOs do not survive on illiterate people. NGOs survive and go to scale on the best talent in finance, in management, in the medical profession, in the technology fields. And how do you balance the act? How do you do the balancing act that you cut down costs, yet give market salaries to your senior and middle management? I think we have achieved that in Operation Asha by cutting costs in other fields, the office space and the infrastructure and the medicines and so on.
Yeah, in our case, we have done a couple of things. For example, using the local infrastructure, such as in case of clinics, how we can partner with the local NGOs who has got some infrastructure in place, which we can convert them as clinics, and as Dr. Shili has also done so in our case, how we can hire local people. For example, the community health workers, they are none other than the members picked up from the community, getting them trained. So we are able to retain, and not only the attrition levels are low, the passion level, the motivation level, and the energy is much higher compared to any person whom you want to bring in from outside. But on top of that, there should be a good mix of right from the ground level staff to the right kind of motivated people as the team leader level who can really guide and foresee the team. And as being a for-profit entity, we have the liberty to design revenue models. So for example, once we see that there is a need gap analysis, we see that there is a demand which has been created on the ground, the patients are looking for some of the additional services. So we have created revenue models, so that also is able to cover some of our costs and expenses, and through this we are able to scale it up further.
For us, it has not been difficult because we use our local infrastructure and we have a very low overhead. So whatever we spend is we spend on medical treatment, medical equipments, and we are using technology. I mean, as simple as mobile phones to get patients. So when the patients, they send us a missed call, a cleft baby is born, and they send us a missed call, we have our counselors who will contact them. Now the most important part is feeding. Now, if the patient comes to us directly at the age of say 3 months or 4 months, and the patient is not fit enough for surgery, patient is having diarrhea, is malnourished or anemic, he has to go back. So that's the cost that he is bearing. So the medical cost is the total cost, the social cost that the patient is bearing, and the treatment cost that we are bearing. So we reduce their cost also, their loss of wages and loss of working days. So We get them to our hospital only when the patient is fit enough to undergo a surgery. So while in the comforts of their home, they can contact our hospital and get the right kind of counseling. And in hospital, we have strict protocols. All the patients have to go through those protocols that starts right from the moment patients enter our hospital. And all these measures help us reduce our cost of treatment.
We get our costs so low. The Golden was complaining this morning that you haven't spent the budgeted money for the past 12 months. So we saved some money for him the last 1 year. The reason is the following, that in medical world, expenditure is equated to cost, which is a wrong notion. Cost is different from what you spend. Most of the medical establishment will tell you our cost is whatever the expenditure was. The question is, do you really know the cost? Most of the medical world does not know the cost of business. So one of the experiments that we do is, what is the real cost of what we do? And I was just telling Golden that this is the real cost. If it is 2 lakhs less, we must have over budgeted because I'm inexperienced, or maybe we cross-subsidize for somewhere else, but this is the true cost of doing business, and that is the money that's really needed. When you extrapolate that number for the country, you can cut down maternal mortality by 70 to 90% in the whole country at a cost of 600 crore rupees, which is 1/10 of NRHM and NHM money. It's nothing, because they are again equating expenditure with cost. In our model, healthcare has been voluntary and do-gooders till 1950 the world over, till 1940. Nobody made profits in healthcare. Then came the profit-seeking behavior of everybody, from doctors to hospitals to MHAs and MBAs, and they converted it. Now the cat is up. It's so difficult to go back. And this is as recent, it's happened within my generation. I've been a doctor for 50 years now. It's happened within my generation. From a non-profit mindset, you become a profit mindset. And your profit is expenditure plus the greed. And expenditure is not the cost. And you wonder where the escalation is going up. Now, because of this, I'm interested in healthcare finance, and we're going to do a project on primary healthcare in Lakhimpur Kheri with the UP government and Gates Foundation, again to find what is the cost of doing healthcare, delivering primary health center care through private entities in a rural area. The project has been approved, will go online for the next few months. And specifically in our case, we apply the same principle of voluntary mechanism. Our bottom line workers, Arogya Sakhi and Swasth Sakhi, are volunteers. Nobody should be paid an incentive for brushing their teeth, for God's sake. They should do it because it's good practice for them. The top of the management and people who work with me, about 80 volunteers, nobody takes the money. I should be smart enough to make my money somewhere else than suck up an NGO. So I get no salary paid, I pay for my own travel, Golden's cost goes down. The only people that are paid are the middle managers we need, and they're all local, pay them the market salary is slightly more than market, depending on the talent, appraisal done every year, usual corporate fashion. So only the middle piece of project managers, program manager, field officers, and field mobilizers, we call them field facilitators. We have about 100 of them scattered in 4 districts. So those are the only ones who get paid. So our cost really is low. Volunteers do not demand money, I can assure you. We have a few thousand of them, they want to do. There are 2 of them downstairs, I think, they move up the ladder, they become field facilitators in our stall. It's interesting, but it is true. Because people join healthcare to do good work, not make profits. If they had to make profits, I tell them, do something else. Go to real estate and go to smuggling or do something else. This is not a profit-making business, for God's sake. Don't muddle it up. It's somewhere along the line, maybe in 10th year of practice or 12th year of practice, you get corrupted. And it's a one-way street. You never come back. Right? Am I wrong in this generalization?
Is there someone who wants to ask a quick question? Yeah.
Good afternoon, sir. My name is Eksoch. I'm a research scientist in the field of biotechnology. And after a long time, I'm at this sector, health sector. And my question is that, being a biotechnologist, I think that there are many possibilities of low cost, there are many possibilities like nutraceuticals we have edible vaccines, we have genetic engineering. Suppose like we have solved that all the skin diseases and that burning faces and skin. We have skin engineering, we call that artificial skin engineering. So my question is that in a country like India, where we divide person in two phases, middle and lower or on a higher status. So for a very low person, a rickshaw puller, suppose he get a burned hand. So how he will get a facility to be the part of like, he will afford that artificial skin engineering facility for his hand. So these are some crucial points which I think that basically I had surveyed all the things. So I came to know that most of the cases are like, no, it's not possible, no, it's not possible. So for a social entrepreneur, being a foundation and I'm a research scientist in biotechnology, so how can we connect with each other to make it possible and like a boom it came for the, like, it's like a blessing for everyone that everyone should afford these upcoming trends which are in trend, but now I don't think so in like country like India only the highest status people can afford it. But how can we make it a smoother one, a parallel relationship? Like
Dr. Subodh.
We are doing one of the biggest genetic research here in BHU. We have the largest sample size of DNA in the world, all coming from a single center. We have found several things new. We found several things which were local to us, right, which were nowhere mentioned in the world, and we are trying to improve upon that. For burns, and in most of the burn cases, the skin is available from the same person's body, and we can also use cadaveric skin for a time being. But then artificial skin, to give you an idea, the 10 by 8 inches of artificial skin on Integra will cost $15,000 in US, right? So the cost is prohibitive to be used in India, but we can do skin cultures. We have been doing for decades in India, in BHU. We have all the polymers. Why can't we make our own artificial skin, which will be much more cheaper? All the good medical equipment, including the endoscopes, microscopes, and anesthesia machines, we are all importing at such high cost that if we make it in India, the cost can be 1/100th or 1,000th of what we are paying it for. So there, say, we are still lagging behind in a lot of research, lot of entrepreneurial activities in these fields, and this is where I look forward to the new generation to come up. See, there is a tremendous need, there is a tremendous market, but there is a little which is being done and produced in India. So there is a tremendous scope, and you can come forward and do it.
Thank you. Yes, ma'am.
And can I address that issue for a second? It is just not the skin. Then you have to fund tuberculosis, then you have to fund MyCare, then you have to fund iCures. So it is issue-based funding can't be done. One axiom I want to say, healthcare is delivered the way it's financed. That's the axiom in the world. So the world has about 150 years experience of healthcare finance. That's the term we use, starting with 1883 by Bismarck in Germany. And we have 150 years of experience. How do you finance healthcare? If we just collated the experience of the rest of the world and created a financing healthcare program, it has to be the following. I'll just very briefly. It has to be a revenue-based, that's a tax-based national health insurance by the center, by the state, with minimum private funding. Insurance companies are toxic to healthcare. This is the world experience. There should be no insurance company. The funded pool has to be a play-up game only between the patient and the provider. It can be designed in a manner that all parties win. That should be the design. And I've said it very brief, on which we have worked a lot, including the National Health Insurance scheme on which I participated. And this is the model of primary health care that we're going to do in Lakhimpur Kheri. How do you finance healthcare, and how do we create a new model? It can't be a US model, it can't be German, it can't be NHS. It has to be Indian model. In that, is there a possibility of creating some funds to find low-cost skins and low-cost CT scanners and low-cost MRIs within the country. So that should be the general overall plan.
Now what's your question?
मुझे कहना ये था कि आपने 4-5 पॉइंट्स जो बताए और मदर के केयर के लिए, मेरा जो एक्सपीरियंस है वो ये कहता है कि हम लोगों को अभी ज़रूरत ये हो गई है कि क्योंकि मैलनरिश्ड है माँ भी, और क्योंकि इस वजह से भी बहुत ज़्यादा डेथ रोल पड़ता है, देन हमें जो एडल्ट्स एंड गर्ल्स हैं उनके साथ स्टार्ट करने की ज़रूरत है। क्या आपके कार्यक्रम में उन लोगों को, क्योंकि अभी गवर्नमेंट के किसी प्रोग्राम में उनको बहुत ही कम देखा जा रहा है बच्चियों के साथ, कि वुड बी मदर जो है उनके साथ हम कैसे काम कर सकते हैं और उनके हेल्थ पे हम कभी स्टार्ट कर सकते हैं, क्योंकि अभी भी यहाँ खासकर यूपी के इस बेल्ट में तो मैरिज की एज जो है 16 ईयर और 18 बिफोर 18 40% से ज़्यादा लड़कियों की शादी हो रही है। तो एक ये पॉइंट ध्यान में लाना था। दूसरा क्वेश्चन आपसे था सर, मैं काम करती हूँ जिस एरियाज में उन स्लम्स में, और वहाँ पे बर्न केसेस भी, यहाँ जो मंडलीय अस्पताल है, आप BHU से हैं इसलिए वहाँ थोड़ा बेटर सिचुएशन है, लेकिन जहाँ कबीर चौरा का जो अस्पताल है उसका जो बर्न वार्ड है, सिर्फ एक डॉक्टर है वहाँ पे, 18 बेड हैं और लगातार फुल रहते हैं और डेथ रोल बेतहाशा है। आप कोई भी एंटर कर सकता है, कभी भी जा सकता है, इन्फेक्शन की स्थिति बहुत ही खराब है। तो उसको लेकर के क्या आप लोग कुछ प्लान कर सकते हैं वहाँ पे, कि उसको सजेशन किया जा सके गवर्नमेंट को और कुछ बेहतर कंडीशन हो वहाँ मरीजों के लिए?
मेरा सवाल आपने जो बताया मुझे बहुत सरल था, कठिन प्रश्न मैं इनको पहले देता हूँ, उसके बाद सर।
पहले तो मैं BHU में अब काम नहीं करता, मैंने अपनी पढ़ाई यहाँ से की है, मैं प्राइवेट बाहर काम करता हूँ, लेकिन बर्न की स्थिति न केवल बनारस में बल्कि पूरे हिंदुस्तान में बहुत ही बुरी है, और किसी भी हॉस्पिटल में बर्न केयर को सबसे अंतिम प्राथमिकता मिलती है, और ये सभी मेडिकल कॉलेजेस में भी सही है। अच्छी बात यह है कि अभी भारत सरकार और कुछ संस्थाएं जागृत हुई हैं और एक नेशनल बर्न पॉलिसी बनी है, जिसके तहत बहुत सारे बर्न हॉस्पिटल खोले जाएंगे, लेकिन फिर ये सभी गवर्नमेंट हॉस्पिटल्स और डिस्ट्रिक्ट हॉस्पिटल्स में ही होंगे। उस क्षेत्र में बहुत कुछ करने की ज़रूरत है, और हम लोग अपनी तरफ से बनारस में जल्दी ही अगले ही 2-3 साल में एक इस पूरे क्षेत्र का सबसे बड़ा बर्न हॉस्पिटल लाने जा रहे हैं, और हम लोग एक ऐसा बड़ा प्लास्टिक सर्जरी हॉस्पिटल बनाने जा रहे हैं जो कि क्रॉस सब्सिडी बेसिस पे चलेगा, जहाँ पे हम लोग 50% पेशेंट्स को बिल्कुल फ्री ट्रीट करेंगे, 20% को सब्सिडाइज करेंगे, और 30% पेइंग पेशेंट होंगे जो कि बाकी पेशेंट्स को क्रॉस सब्सिडाइज करेंगे। इस मॉडल पे हम लोग जल्दी ही काम स्टार्ट करने जा रहे हैं, और हो सकता है कि 2 साल के अंदर इस देश का एक सबसे बड़ा बर्न हॉस्पिटल और प्लास्टिक सर्जरी हॉस्पिटल आपके इस क्षेत्र में उपलब्ध होगा।
मैंने अपने भाषण को संक्षिप्त रूप में रखने के लिए खाली 5 मुद्दों पर बात की। वो केवल हमारा प्रोग्राम नहीं, हम किशोर अवस्था की बालिकाओं से बात करते हैं, उनको पोषण के बारे में बता रहे हैं, प्रेग्नेंट औरत जो है गार्भिक अवस्था में उनको पोषण क्या चाहिए उसकी भी हम चर्चा करते हैं। 5 मुद्दे में इसलिए बता रहा था कि अगर ये कार्यक्रम इतना सरल हो सकता है, इसको ज़बरदस्ती कॉम्प्लेक्स बनाने की कोई आवश्यकता नहीं है। किसी भी प्रोग्राम में, चाहे बिजनेस में नॉन बिजनेस में है, 4 असूल होते हैं: सिंपल, स्केलेबल एंड सस्टेनेबल एंड स्पीड। चाहे बिजनेस में जाओ, चाहे आप नॉन प्रॉफिट में जाओ, अगर आपने इसको सिंपल और सरल नहीं रखा तो आप कहीं नहीं पहुंचोगे। तो इसलिए मैंने संक्षिप्त 5 मुद्दे बताए। हम किशोर अवस्था में काम करते हैं, बालिकाओं से काम करते हैं, हम बुजुर्गों के साथ भी काम करते हैं, और हमारे इलाके में यादव जी बताएंगे जिस इलाके में हम काम करते हैं, अंडर ये हमारा पॉपुलेशन स्टेबलाइजेशन प्रोग्राम के अधीन आता है, अंडर 18 बालिकाएं ओनली 5% शादी अंडर 18 होती, 95% अबव 18। इतना तो हम सफलता पा चुके हैं।
I just quickly add to जैसे हमारे केस में भी 9 to 14 years of जो teenagers girls हैं, उनके लिए we especially focus on nutritional kit, which is something called a nutritional kit, which has been specially designed to focus on the nutritional behavior awareness and how by the time they grow up to mother stage, they are fully aware of all the nutritional values and how they can take care of them. In addition to that, we also understand that in a family, only the mother is not the stakeholder. In this case, the husband, the father-in-law, the mother-in-law, they all are the stakeholders, and even the community. So we have several layers of awareness building mechanisms, and we try to sensitize the entire community, right from the community to all the stakeholders, about the essential nutrients which should be there for the mothers.
I'd like to make one more comment here about the political will that is missing in a lot of well-intended government programs. See, when the country gained independence, so 1947, what happened? We had so many of these programs. We had the National TB Control Program, Malaria Control Program, Integrated Child Development Scheme, Mother and Child Program, etc. How many of them are working and how many of them are delivering results? They all exist. What is the outcome? What is the impact? And is the impact being measured, and is it being measured accurately or not? That's the million-dollar question. The second thing I want to make is that when you see the health indicators, the maternal mortality, undefined mortality, infant mortality, our results are shameful in India. Bangladesh is doing better than us. We have to hang our heads in shame when we go across the globe and they say India is doing so badly. How do we explain it? One of the reasons is that the GDP, the percentage of GDP that is being spent on health is abysmally low, and it is shameful what we are spending. So unless there's political will, the doctor-patient ratio will always be skewed. You need more doctors in public hospitals. You are saying there's one doctor for 15 patients. Believe me, Safdarjung and other hospitals, one doctor, hundreds of patients, 2 on the bed, 2 on the floor. So it's a horrible situation, and we will have to, I think, at our level, we are all working for nutrition, for mother and child, for everything we are doing. But unless the government takes a very strong step forward, there's not going to be any systemic change. Of course, individual efforts will always be there.
I think one was that they increase the age of retirement, and is the way forward. I mean, it's a very small thing, but maybe. They increase the age of retirement for doctors very recently, you know. What I'm saying is,
small step.
but even that has not been done. That's what I'm saying.
डॉक्टर रिटायर तो होते ही नहीं है
हाँ,
अगर अस्पताल में कहीं बाहर काम
नहीं
करते हैं
बाहर करते हैं, लेकिन गवर्नमेंट में तो नहीं करते ना.
उसका रिटायर में कोई फर्क नहीं पड़ेगा तो इस दुकान पे नहीं बिठा दो उस दुकान में बिठा दिया उससे कोई फर्क नहीं पड़ेगा डॉक्टर पेशेंट रेशियो में. मैं हमने सरलता की बात जो मैं बता रहा था, देखिए न्यूट्रिशन जो है जो मेरा एक सब्जेक्ट है उसको आप देख सकते हैं माइक्रोन्यूट्रिएंट, न्यूट्रास्यूटिकल्स और विटामिन्स, प्रोटीन, ऐसा क्यों कॉम्प्लिकेट बना रहे. हम अपनी महिलाओं को सिखाते हैं चतुरंगी भोजन. एक सफेद रंग का खाओ, एक हरे रंग का, कोई लाल रंग का, पीले रंग का. उसको बाटे उसका अगर विश्लेषण करेंगे ये सारी चीजें मिल जाती हैं. तो या तो आप बोलो चतुरंगी भोजन खाओ या माइक्रोन्यूट्रिएंट से बात करो, तो अपना सरलता से काम कर करें तो मैसेज उस पार चला जाता है. कम्युनिकेशन इज नॉट व्हाट यू से, कम्युनिकेशन व्हाट द अदर पर्सन हर्ड, दैट इज कम्युनिकेशन. हमारा ख्याल हमने भाषण दे दिया सब ठीक हो गया. Unless you're Mr. Modi, nobody listens to you.
You had a question, and we'll take the last question and then we'll go.
Dr. Batra, you had spoken about both the lack of critical will and the need for impact evaluation, and I completely agree with both of those. And once organizations, such as the ones that all of you are running, once they start doing that, what is the way forward to create evidence-based policy for the government public health system based on your initiatives?
Impact evaluation has to be there, whether it's in the NGO sector or in the government sector. And before that, I'll take a step backward to say again about Bangladesh, that Bangladesh has largely decentralized healthcare. So the healthcare is not solely in the hands of the government, it's been farmed out to the NGOs. Now in the government there is less of accountability, less of transparency, and maybe 40% absenteeism has been reported, which cannot be there in the private sector when we are all part of the private sector, and we believe in work that has to be done. And now we come to the very important issue of how do we evaluate. Third-party evaluation is of vital importance. Randomized controlled trials, before and after studies like they have done in the SMILE train, before and after evaluation of the MCH programs. I think all these go a long way. Like we have done 2 randomized control trials with MIT JPAL, one on incentive-based salaries, one on e-compliance. So do incentives lead to better detection? Yes or no? Unless you randomize 2 cities, you don't have any results. So I think research can play a very, very important role in having very good, truthful accounts of what is actually happening at grassroots level.
I know you all 4 have great stories and great experience. It's pity that we don't have much time, but really thank you, so much because I see a lot of points that we were able to discuss. Keeping our intervention simple and ensuring that it reaches the last mile, and then being able to measure that, right? So I think those are some of the important things that we were able to talk, and also even technology. Use of technology about how it should come from the ground, and it should be a need-based rather than something fancy coming around. So some very important points there, and using the infrastructure that is already existing to reduce your cost. I think Dr. Ganju and we've seen that happen on the field. So that's amazing work that you are all doing. So I think those are some points. I think we'll break now. I know we're all hungry, so we can go have lunch and then after that move on to the next session. Thank you.
Sir, yes, I have to buy this.
Let's get a picture done now.